Welcome to Department of Medicine Grand Rounds. Thank you all for joining us, both in person and on Zoom. I'm Bob Wachter, chair of the department. Very excited about today's talk because we're really talking about some cutting edge stuff by one of the really world's experts in the topic. So the topic is redefining sudden cardiac death with the POST-SCD study. You'll learn about that study. Clearly, despite a lot of advances in our understanding of cardiovascular disease and decreasing mortality from lots of cardiac diseases over the last 20 to 30 years, people still experience sudden cardiac death, and what we know about it is limited, and it's clear that when it happens, it's devastating, and there is more to be learned about the predictors of it, how to prevent it, and probably the molecular underpinnings of it. And we are very fortunate that one of the world's leading investigators of that is Zian Tseng, who's on our faculty. Zian is a cardiologist and a cardiac electrophysiologist. He's clinically active, but spends most of his time studying the issue of sudden cardiac death, and has created a number of unique collaborations, including with the San Francisco Department of Public Health and Coroner's Office to get the data that he needs to help us deepen our understanding of this syndrome, what it's about, and and how to lessen the burden of it. He's principal investigator of a number of studies funded by both the NIH, the CDC, and others that has really put him in a position to help educate us and others about this issue. Zian is as close to a barrier lifer as I think I've met in my time here. A lot of people are itinerant, but Zian was born in San Francisco region, I guess in Fremont or around there, went to school at Berkeley, probably only because we didn't have an undergraduate school. And then came to UCSF for his residency, for medical school, for his residency, for his fellowship in cardiology and his subspecialty training in electrophysiology, and joined our faculty in about 20 years ago, I guess, and has been on faculty and really a stellar performer in our faculty ever since. So really looking forward to hearing his comments and learning more about the syndrome. Thanks.
Well, thank you, Bob, for the invitation and also for the introduction. Just a clarification, I was born in San Francisco, and so I've actually never left a 40-mile radius of the city in my life. And for the trainees in the audience, be careful coming here because you might stay here, and UCSF really does stand for you can stay forever. So, but if you do stay here, you can do some amazing things. My disclosures, I may be the only electrophysiologist in the country without any industry disclosures, and you'll find out why a little later. So let me start with this slide. So any review paper or grant on sudden cardiac death starts with statistics, which say that sudden cardiac death is the #1 killer, more than the other top 5 causes of death combined. But this is based on death certificates. And what are death certificates? They're just the best guess of the last clinician to have seen the victim. And so why is heart disease the #1 killer? It's because we say it is. And if you look at the long-held paradigms of sudden cardiac death, this is taken from a review article about 20 years ago now. If you start from the bottom, what we're talking about when we say sudden cardiac death are all of the rhythms, so ventricular fibrillation, ventricular tachycardia, asystole, the rhythms that can be rescued with a defibrillator. And then proximate to that are the triggers, so the environmental influences, ischemia, acute heart failure. But the substrate, it's been thought to be 80% coronary artery disease, so acute causes such as acute MI, or chronic scar from MI, such as ischemic cardiomyopathy. That's thought to be about 80% of all causes. Then about 10 to 15% are the structural causes like cardiomyopathies, hypertrophic or dilated. And then the rare causes, less than 5%, are maybe the cases I might see in my clinic, the channelopathies, the rare inherited conditions. So this has been the construct for 20 plus years, if not more. Let's peel back the onion and talk about how do you study this condition without defining it properly. So definitions have traditionally been based upon death certificates, like I showed you. But from the EMS side, they rely on EMS run sheets and CARES criteria, which is simply EMS primary impression of cardiac arrest. So if you imagine a paramedic coming on scene to a victim, if they say primary impression cardiac arrest, that's declared a cardiac arrest by their definition. On the epidemiologic side, we in the societies, ACC, AHA, Heart Rhythm Society, World Health Organization have settled on this definition. which is witnessed death within 1 hour of symptom onset, or unwitnessed death within last 24 hours of last being seen alive and symptom-free. So that's the definition. Now, I would say that defines suddenness, but does that really mean cardiac? And again, all these are presumed cardiac definitions. So I'm not going to review every one of the definitions in all of these cohort studies and trials. Suffice it to say, it's the same definition that's used in all these studies, including the VEST trial, which was led by Jeff Olgan and Byron Lee in our division. Same definition, World Health Organization, presumed sudden cardiac death. So this is a great illustration of the problem. As you may recall, about 8 years ago, one of our Supreme Court justices died suddenly at a ranch in Texas. His death was declared a sudden cardiac death without the coroner even viewing the body, let alone ordering an autopsy. And the coroner in this case happened to be a county judge. So this multiplied by 500,000 is what we've been calling sudden cardiac death. So has this definition been naked? So if 90% of sudden cardiac deaths occur out of the hospital, they're in the jurisdiction of the coroner and medical examiner. And they're too busy with the forensic cases, the homicides, the suicides, the traumas, and they only autopsy then 10% of cases overall, and maybe a little bit higher in European countries, Finland about a quarter of cases. Then the original Hinkle-Thaler study, which defined the term arrhythmic death, this is 40 years ago now, was based upon 82 cases, and only a quarter of those are confirmed by autopsy. So really, what are we defining here? So on the other side, the autopsy studies that define the 80% of cases due to coronary disease, the 10 to 15% due to cardiomyopathy, that's the 10% that got autopsied. So on both sides of the coin, you have significant bias in terms of the part of the picture that you're really looking at for sudden cardiac death. So here I'd like to make the distinction between sudden cardiac arrest survivor and sudden cardiac death. And so we see the lucky few that make it to the ICU, the CCU, the cath lab, and maybe finally get discharged to our clinics. That's the lucky few above the iceberg. Below the surface, these cases go to the medical examiner in the corner, and they only investigate these cases 10% of the time. So what are we really talking about when we say sudden cardiac death? And it doesn't take a layperson to really understand it could be any one of these conditions that causes you to collapse and die suddenly. Yet what we're trying to identify in all of our research, in all of our trials, in all our risk calculators, in all of our genetic studies, are arrhythmic deaths. So essentially, we've been equating that condition with what are the cases that we can really rescue with a defibrillator, because that's what we're trying to identify. And the causes in gold here are really the limited causes that could be rescued by a defibrillator. And so if you were to study this condition, you need to start in the community, because this is where all these cases are happening. You don't study just the cases that get rescued to the hospital or to the clinic. So how do you do this? One of my inspirations was this study about 20 years ago. Sumit Chugh out of Oregon Health Sciences University started this study, Herculean effort by him. He tracked every single cardiac arrest in the community, every ambulance, every emergency department, and put together all this amazing data. And he's published a number of insights on this condition from that cohort. Now, if you peel back the onion in his study, only 11% of cases were confirmed by autopsy. If you flip it around, 9 in 10 of his cases are presumed to be cardiac. So that got me thinking, well, we really need to find out exactly what the causes of death are here. And instead of working with every single ambulance and every single emergency department, I just go down to the end of the funnel, because every one of these cases, if you die out of the hospital, have to be reported to the medical examiner. And so that's the perfect surveillance method. They're not going to miss any single case. So in 2010, I decided, let me pick up the phone and call the medical examiner. And I was lucky enough to be connected to a junior medical examiner at the time, Dr. Ellen Moffitt, who I amazingly convinced to start this study. And so we've been doing this since 2010, where we deeply investigate every single sudden death that occurs in our county. And so a few years ago, we published the first 3 years of this study. First, let me review the demographics of our county, which by its diverse nature gives us the power to study all these different subgroups because of the diversity. We have 10 hospitals, 3 ambulance companies, fire department in response to 85% of calls. Our population is about 850,000, growing to about 1.5 million. This is pre-pandemic. Now with work from home, it's probably less than that, but approximately 1 million or so cases, that catchment area that we get. So during the study, we first start with all 20,000 deaths occurring from age 18 to 90. And so someone asked me, I remember, well, why are you studying 80-year-olds? Because traditionally sudden cardiac death has been focused on the young population, under 40, under 50. And I said, well, we're putting in defibrillators in 85-year-olds. So why should we not study causes of sudden death in 80-year-olds, right? So starting with 20,000 deaths, the ones that get reported to the medical examiners are the ones that occur out of the hospital. So that's about 12,000 cases. From those cases, every morning we would review the EMS run sheet, the scene investigation, and pick out the cases that EMS had called cardiac arrest. They didn't make it, they didn't get resuscitated, they were called cardiac arrest, they died, they went to her office. She pulled those aside and approached family for consent for autopsy, and she did almost 900 autopsies in the first 3 years. So an amazing 97% autopsy rate of those cases. Now, once we got the autopsy in those cases, then we went and pulled every single one of their past medical records, the EMS run sheet, family interviews, and confirmed that they met sudden death criteria. In fact, 371 cases did not meet sudden criteria, or we found an alternative cause of sudden death, like drugs at the scene or evidence of trauma, or maybe they had chest pain for 5 hours rather than under 1 hour. So those were thrown out. So that's 371 cases of the 900 cases that she autopsied did not meet sudden criteria. We call them non-sudden deaths, but that left 525 cases over 3 years in our county that would have been called sudden cardiac death in any other study. So here, let me share a first case. I think these examples are really illustrative. So this was a 74-year-old gentleman who had ischemic cardiomyopathy, EF at 22%. He was admitted for fever and bronchitis, getting IV antibiotics. I was consulted. This is actually my own case. I was consulted because he had NSVT and, can you implant a defibrillator? And I said, well, he's infected. Let's up titrate the beta blocker. Let's schedule him for an ICD as an outpatient. 2 weeks later, he was discharged, went home, and his wife found him dead the next morning next to him. And I said, oh my gosh, I missed the opportunity to implant a defibrillator in this case. I didn't, and the referring MD was really upset. At autopsy, he had a perforated duodenal ulcer. So 2.5 liters of fresh blood in the GI tract. So he died of a GI hemorrhage, exsanguination. ICD would not have saved him. In fact, would he have even survived the procedure? So here I'm showing you all the autopsy etiologies, every single one of those World Health Organization defined sudden cardiac death. Again, every one of these would have been considered sudden cardiac death in any other study. So in red are the arrhythmic causes. So these are the cases that would have been saved by defibrillator. So no alternative non-arrhythmic cause like pulmonary embolism, like hemorrhage, like aortic dissection, like acute heart failure. Collectively, about half, 55%, 56% would have been saved by defibrillator. Among those cases, about 18% were acute coronary disease, 22% chronic coronary disease. So collectively, if you add this up, about half of the arrhythmic causes, not 80%, but half of the arrhythmic causes of coronary disease. 10% are due to cardiomyopathy, another 10% hypertrophy, and then the rare normal heart primary electrical disease are here at about 1%. And here's again the distinction of a cardiac sudden death, but non-arrhythmic. So these are cases where we found acute heart failure with pulmonary edema at autopsy, or MI with wall rupture and tamponade. So those have been cardiac cause of sudden death, but would not have been rescued by a defibrillator. Now, if you consider those cases plus the 40% that are non-cardiac, nearly half of traditionally defined sudden cardiac deaths are not cardiac at all. And if you look at our case, it would have fit right here under GI hemorrhage. About 3% of our cases are GI hemorrhage. So because I collected every single case in collaboration with the medical examiner, I can calculate rates of sudden death by whichever definition you choose. So if you use the EMS definition, that's about 40% higher than using the WHO definition, because as I said, some of these, if you look carefully, had an alternative cause of sudden death or didn't meet sudden criteria. But if you look at these cases, after autopsy, only about half of those are actually arrhythmic deaths. Okay, so truly, the specificity obviously improves with the level of investigation. Now, if you look at the various subgroups, whether you use the WHO definition or autopsy definition, the rate of sudden death in men is about double that in women. And you see these racial disparities as well, where the highest rates are in Blacks, followed by whites and then Asians and Hispanics. So Satvik Ramakrishna, who was a medicine resident and then a cardiology fellow, worked with me for a number of years. He led this sub-study on sex and racial differences. So as I said, the power of our county is that we have diversity to look at all these different subgroups. So what if you look at the highest rate of sudden arrhythmic death confirmed by autopsy? It turns out to be in Black women. if you use reference whites as one, Black women had a 2.5-fold higher rate of arrhythmic death. So this is despite excluding all the non-cardiac causes. Using that same reference, Hispanic and Asian men are about half that of white men. So clearly, ethnic differences in risk. Now, what about in women versus men? Turns out, if you look at the cause of sudden death in men, about 60% are indeed arrhythmic. In women, less than half are arrhythmic. So more non-cardiac cause of sudden death than a woman. So in other words, you encounter a woman who dies suddenly, less than half of the time is it actually cardiac. The remainder were hemorrhage or neurologic causes. So this gives justification to study these cases separately, because the cause of sudden death are different in men and women. Causes of sudden death are different in Blacks versus whites versus Asians versus Hispanics. So here's a second case, 71-year-old gentleman who had ischemic heart disease. He had bouts of syncope, so he had a loop recorder placed. He was found unconscious by his wife. EMS was called. He was found in asystole. Resuscitation was attempted without success. So at autopsy, we found the coronary disease, no acute MI, hypertrophy, cardiomegaly, but he had a loop recorder. So we had the opportunity to interrogate his loop recorder. This was a study written by Emily Siegel, who was a medical student at the time, and now she's a medicine resident. And so here I'm showing you the loop recorder interrogation at the time of sudden death. And as you look through the rhythm, you start with second-degree heart block, Mobitz 1, progressing to Mobitz 2, progressing to complete heart block. So, aha, he had asystole or heart block as the cause of arrhythmic death. Well, in fact, by toxicology, his fentanyl level was double that of the lethal threshold. So in fact, he died of an overdose. And how does fentanyl kill you? It causes respiratory depression. So the asystole and heart block was secondary to respiratory depression. In fact, if you do a thought exercise and say, what if I had put in a pacemaker before this happened? He still would have died of respiratory depression. So the rhythm doesn't tell you the whole story. And so this turned out to be the number one, the biggest part of the pie in terms of non-cardiac causes. About 1 in 6 of cases were actually due to overdose. And the only way you're going to pick this up is you do toxicology in every single case, which is never done. In fact, if you extrapolate these numbers in our study to nationally, and nationally it's estimated about 400,000 cardiac arrests. If 1 in 6 of those are actually overdoses, that's 60,000 missed overdoses in the country, which is about double what the recognized rate of overdoses is. And so you might think, well, is this a San Francisco only problem? Is this an urban problem? This is a great study by one of my friends in Denmark. He went back and looked at 600 autopsy sudden cardiac deaths. They pulled the blood sample and did toxicology. More than half of those cases had positive toxicology. So this is a problem worldwide. What about urban versus rural? Over here's overdose rates in urban and rural areas completely overlapping. So this is a problem wherever you live. How can we feed that information back to rescue these potential cases? So in San Francisco, I partnered with EMS and we started doing this, implementing Narcan at the scene of cardiac arrest. It's a cheap, quick, and practically harmless intervention to say, and you can save those potential cases. Here's a third case, 78-year-old Asian woman, dilated cardiomyopathy, primary prevention ICD. She's on anticoagulation for atrial fibrillation, usual state of health. Husband went shopping, and he came back. She was dead on the floor, already clearly dead. EMS called it cardiac arrest, of course. No resuscitation was attempted because she was in asystole. Again, she has an ICD. So for those of you who are not familiar with ICD, here we have sinus rhythm with paced ventricular beats going to ventricular fibrillation, which was successfully shocked back into sinus rhythm. This occurred 32 times on the defibrillator. So this would have met any cardiologist or electrophysiologist adjudication criteria for arrhythmic death. At autopsy, she had a massive subarachnoid hemorrhage. Okay, so I learned playing CSI in all these cases that you need a perfusing rhythm to have that volume of blood. So the subarachnoid hemorrhage caused the VF, not the other way around. She didn't have VF collapse, hit her head and have a subarachnoid hemorrhage. So we also, for those of you who work in the neuro ICU, you see with high intracranial pressures, these runs of an SVT all the time. So there's this neurocardiogenic connection. the cause of death was neurologic despite rhythm documentation and ventricular fibrillation. Turns out this is the second largest cause of non-cardiac cause of sudden death. And we coined this term sudden neurologic death to capture these cases that are hidden among cardiac deaths. And this would include the subarachnoid hemorrhages, subdural hemorrhages, and this condition called SUDEP, sudden unexplained death in epilepsy. I learned this myself in doing the study. In fact, early on, I decided we need a neurologist on our panel to adjudicate these cases. And I remember Anthony Kim, this was led by Anthony Kim, who at the time was a junior faculty. He's now the leader, the director of our stroke center. He was saying, gosh, the picture of these cases is completely unlike what I've ever seen. And I said, well, you see the survivors. You see the ones that made it to the hospital, who got diagnosed, who got an MRI. You see the survivors. We're seeing the severe manifestation, the most severe manifestation of all these neurologic diseases that present suddenly. So the risk of these causes are higher in women. And obviously, if you're on antiplatelet and anticoagulate medications. Now, if you extrapolate our study of the 5% of sudden deaths that are due to neurologic causes, that's potentially 25,000 sudden neurologic deaths missed annually in the United States. So that would be approximately a 50% increase in fatal intracardiac hemorrhage, intracranial hemorrhage incidence in the United States. So that got me thinking, despite deep postmortem data, we're going to call every one of these sudden cardiac deaths with the same data if you use a panel of cardiologists and electrophysiologists, right? So can we possibly quantify the degree of misclassification? So what happened was I've been partnered with Oren Davinsky, who's the world expert in SUDEP and epilepsy. And he said, why don't you send me every one of your cases that had any history of seizures? And I'm going to re-adjudicate those with the same data. I want to see how many SUDEPs you have. So he adjudicated 25 SUDEP cases with his team versus the 7 that we originally reported in the article. And so, in fact, it's over 3-fold more SUDEPs if you use his point of view. So this has implications for adjudications of mortality anywhere in any study. Beauty is in the eye of the beholder. So if you have a panel of cardiologists, they're going to call it cardiology causes. If you have a panel of neurologists, they're going to call it neurologic causes. So it's really important to have a diverse viewpoint as you think about these adjudication panels. So what about the long-held association of QT prolonging medications and sudden cardiac death? Could that be confounded by all of these non-arrhythmic, non-cardiac causes that are really underneath the hood? And so this study was led by Tim Simpson, who, as a medicine resident, he's now actually an interventional cardiologist in the Portland area, and he's actually a trained pharmacologist. So what he did was he quantified the QT prolonging medicine exposure in all of our cases compared to 100 trauma cases. And then we peeled back the onion and looked what were the actual associations between causes of sudden death. So if you look here at the top, based upon tertiles of QT prolonging medicine exposure, indeed, with each tertile, low, medium, moderate, or high, you had a higher rate of sudden death, higher over here on the right, lower on the left. But if you look at the actual causes, the association was actually stronger for non-arrhythmic causes. Now, we're not saying that QT prolonging medicines are not associated with arrhythmic death, because indeed, if we had enough cases and more power, these certainly would be significant. But in fact, the association was stronger for the non-arrhythmic causes. So why would that be? Turns out it's confounding by indication. So for example, if you were prescribed methadone, it turned out you're more likely to die of overdose than an arrhythmic death. If you were prescribed erythromycin for your pneumonia, you're more likely to die of the pneumonia than of an arrhythmic event. So if you have a window into every single one of these cases, you can look at the important subpopulations. So early on in the study, I started noticing how come there's so many HIV cases dying suddenly. So I picked up the phone and called my old chief fellow, Priscilla, who's now, of course, the chief of cardiology at the General, and she's a world leader, an HIV cardiology pioneer. I said, have you noticed this happening? And so she said, no, I don't think I've ever really looked carefully. So what we did was we went back, this is early on, about 10 years ago, we decided, as the study was just starting, we decided to go back and quantify and recharacterize all the deaths in Ward 86 over the prior 10 years. And we found, using the presumed definition, that the rate was 4.5-fold higher than for uninfected victims. And so this got a lot of press. It was picked up by New York Times. But that gave us the opportunity to look carefully at that subpopulation. And so a couple of years ago, we published the HIV post-SCD substudy. And here we used the same methods every single HIV case that was referred to medical examiner. She approached the family for the cases that were called cardiac arrest. We did autopsy, and that left 47 cases over the initial 6 years of our study, or 5 years of our study. And the causes of death here are similar, with the exception of overdoses being about 3-fold higher. And of course, that makes sense because a lot of the health-related behaviors are overlapping in the HIV population. Now, what if you look at rates by autopsy? Is it truly 4-fold higher than we had first reported? Well, it's actually about 2-fold higher, 2-fold higher. So indeed, still a higher rate of arrhythmic death among people living with HIV. And even despite excluding all of those overdose causes and all the other non-cardiac causes, still nearly 2-fold higher rate of arrhythmic deaths. So with autopsies, we can begin to see what's mediating this phenomenon. So we looked at all the autopsy results, looked, is it due to coronary disease? Is it MI? Is it valvular disease? Is it mass? Are these hearts heavier? Turns out there were no differences in gross pathology, including no higher rates of coronary disease, contrary to what the long-held association, perhaps our treatment for people living with HIV is better. They're on statins now. We also are getting better at primary prevention of coronary disease. So, we didn't find any differences. However, if you looked at histologic differences, this is trichrome staining of the myocardium, which stains fibrosis blue. Over on the left are all the HIV cases, or on the right are the reference uninfected population, and you have the arrhythmic causes and the non-arrhythmic causes. Suffice it to say, when you use a computer to quantify all the blue pixels compared to all the red pixels, there's about 70% higher burden of fibrosis in these myocardium of people living with HIV. And it's actually the interstitial form of fibrosis, not the confluent myocardial fibrosis, replacement fibrosis that occurs, like, for example, with myocardial infarction. It's interstitial fibrosis, and that form of fibrosis is very difficult to pick up by MRI, for example. So what about other vulnerable populations? So this, you guys may have seen this recent study we published a couple months ago, led by Leila Hagegat, who is currently, I think, currently a structural echo fellow and was chief cardiology fellow last year. And so in our county, we can quantify the risk for sudden death based upon housing status. And so indeed, if you look at rates of sudden death in housed population versus unhoused population, it's about 16-fold higher rate of sudden death in the unhoused population. And even excluding the non-cardiac causes, approximately 7-fold higher arrhythmic deaths. Okay, so that might sound astonishing, but other research has shown approximately 10-fold higher rates of overall mortality. So here we're looking at sudden mortality, and that's about 16-fold higher. And so if you look carefully at the underlying cause of sudden death in the homeless population, can we feed that back and try to prevent those causes? So as I said, despite peeling back all the non-cardiac causes, the arrhythmic death rate is still 7-fold higher. But among the non-cardiac causes, as you see here, overdose was much higher, about 3-fold higher. And then infections were also about double. Okay, so how would you feed that back? Well, perhaps more or earlier access to AEDs and reversal agents in the homeless population might help reduce those causes. Continued efforts to reduce substance use, and then focused or targeted vaccination drives might save those infection causes as well. So here's another case, 74-year-old Black gentleman with coronary disease, pacemaker for complete heart block. And he had reached what we call elective replacement indicator, which means battery is at the reserve meter. And if you think about your car, light blinks when the gas is running low, you sort of reach that point, and you have about 6 months to change the battery. He's pacemaker dependent. And so we actually, because he was pacemaker dependent, despite having 6 months, we scheduled him in 5 weeks to get the pacemaker battery change. And he didn't show up for his procedure that morning. So my fellow called his home, and his wife picked up the phone, and she was distraught. And she said, he passed away last night, suddenly. And so this became one of our cases. And at autopsy, He had no acute MI, no pulmonary embolism, negative toxicology, no bleed. So negative autopsy with the exception of finding his underlying heart disease. And here what I'm showing you on top is the pre-mortem interrogation. So this is the interrogation when he had reached ERI. As you see here, the company said we had 6 months left of battery. His voltage was 2.63 volts. He was pacemaker dependent as corroborated here by the ventricular pacing rates of 95%. Post-mortem, after autopsy, we did the interrogation. You see here that his battery voltage had dropped by 0.5 volt. So this is catastrophic battery failure that was unlucky to have happened that night before we did the generator change. Despite the company telling us we had 6 months, we actually had less than 5 weeks to do the generator change. And lest you think maybe, well, did he have ventricular fibrillation? Well, the pacemaker can tell us that, right? So ventricular high rate episode 0. So this was not ventricular tachycardia. This is not ventricular fibrillation. This was pacemaker battery failure. And so using our study, we can quantify what is the burden of sudden death due to device malfunction or device problems or device failures. And so this was led by Rob Hayward, who was EP fellow at the time. And so what he did was look through every single interrogation. In fact, initially we'd go to the medical examiner's office, do these interrogations, and then we actually had the device companies come. And then now actually Dr. Moffat herself helps us with interrogations. She's probably the only medical examiner in the world who can do that. So what we found was about 4.5% of all these sudden deaths had a device. And in those devices, about half of them had a device problem. And in that half, about half of that were frank device malfunctions. So I'm talking about battery failure, I'm talking about lead fractures, undersensing, what have you. So about 1% of all sudden deaths is due to device malfunction. So that seems, modest, but the device companies tell you that the failure rates are about 1 in 100,000, 1 in 200,000. So this is orders of magnitude higher than the device companies publish. And so you might think, well, wait a minute, how can that be? How can this failure rate be so high? Well, in fact, if you die suddenly with a device that was designed to have prevented that event, and you had that event, it's actually quite likely that device might not, it had something wrong with it that didn't save you from that event. And that's exactly what we saw. And so here's another example where just doing the device interrogation, you would think, okay, well, the patient had multiple rounds of VF and got shocked and, unfortunately died of an arrhythmic death despite VF shocks. Well, if you lined up the EMS run sheet with what the interrogation tells us, actually, there were missed VF events by the defibrillator. The defibrillator wasn't even doing anything because it thought that it was in normal rhythm because it had undersensed the ventricular fibrillation. It required EMS to be externally shocking this patient. So in fact, in this case, it was device malfunction due to undersensing of ventricular fibrillation. Here's another one where at the time, unfortunately, of VF event, the shock triggered a lead fracture. Okay, and by the way, this lead was not one of the leads that device companies told us needed to come out, needed to be recalled. This was one of the ones that they said it was safe to implant, right? And so these are cases that are completely missed. And so the way we surveil for device problems in our country is a database called MOD. And how does MOD work? It's voluntary, number one. And number two, it requires you to be alive. You have to be alive for us to pick up that problem, right? And so this issue is sensationalized a little bit by this reporter, but the fact remains that these problems are hidden in every single medical examiner's office, every single corner. And the only way to pick up these problems and improve design of these devices and improve our programming is to deeply examine all those cases. So I have started to feed that back into my own practice, and I'm hoping that for those of you who are interested, I can share some of the things that I've done as well to save these cases. So shifting gears a little bit, this was another study led by Satvik, who looked at the burden of heart failure among all of our cases. And so looking at all of our cases, how many of our cases had underlying heart failure? And what were the characteristics of those? And what were the potential cases that we could have saved using our guidelines? And so approximately 1 in 5 of our cases were due to heart failure or had heart failure. And as you see here, so about 100 of our 525 cases had heart failure. And of those 100, about half were due to HFrEF, So reduced ejection fraction, about half of our heart failure cases had reduced ejection fraction, and about a third were preserved ejection fraction in the middle. And then 15% were completely missed, completely undiagnosed. The only way we picked it up was at autopsy. Patient, him or herself, had no idea that they had heart failure, had not seen a doctor, had no diagnosis. So this is fills the complete picture of what's the burden of heart failure among sudden deaths. And so this is a little bit of a busy slide, but I'm going to focus on 2 points. So if you look at the slice of the burden of sudden death that has heart failure, only 22 cases would have met our current guideline criteria to get an ICD. Okay, so put it another way, our guidelines for primary prevention ICD implantation would have saved only 8%. Only the sensitivity is only 8% of all arrhythmic deaths in the community. The other thing I want to point out is, okay, what are the characteristics of these cases, these 100 cases who have heart failure? What kind of treatments were they on? Turns out only 6% of those cases were on goal-directed medical therapy. Okay, so it's only 6%. And so we can do all the research we want and spend all this money on expensive clinical trials and ICD trials, but that is not getting to the community. Only 6% of our patients were on goal-directed medical therapy. So let me return to this slide and the distinction between sudden cardiac arrest and sudden cardiac death. And again, I told you what we see is sudden cardiac arrest survivors, and sudden cardiac deaths are the ones we never see. It's the medical examiner seeing those. And we've always presumed those without knowing, without looking. And so my colleagues in the field, let me put it that way, have always critiqued our study and said, well, you know, you haven't captured the sudden cardiac arrest survivors. Those are the same, right? How can how can you say they're different if you haven't studied those? So Santo Cherry, who was a medical student and a resident here, he worked with me for a number of years. He did the Herculean task of tracking all of the cardiac arrests that made it to the hospital, got resuscitated, and what happened to those, so that we can compare those to the ones that did die suddenly out of the hospital. And this is an extension of our study. We called it the post-SCA study, sudden cardiac arrest study. And so let me take you from the top. For all the out-of-hospital cardiac arrests that occur, the majority died out of the hospital, which are the first pie. We've already reported those. I already showed you those. The majority die suddenly out of the hospital. That's approximately 56% of cases were arrhythmic. Okay, so what happens if you got resuscitated? And it turns out about 18% were lucky enough to have been resuscitated from the cardiac arrest event, make it into the hospital. 18%. Okay, in that 18%, 65% mortality. No surprise. Initially resuscitated, you still have a very high mortality rate. And of those cases, so of the 65% that died, mouse is not working. That's the second pie. The causes of sudden death in those cases were nearly the same proportion as if you died out of the hospital. So put it another way, if you have cardiac arrest, you die out of the hospital, nearly half are non-arrhythmic. If you were resuscitated, lucky enough to be resuscitated to the hospital, you still die. The proportion of the causes of sudden death are nearly the same. Whether you die out of the hospital or die in the hospital after your initial resuscitation, approximately a half of those are not arrhythmic. Okay. Now, what if you're the lucky 47 cases out of the original 734 that got discharged, resuscitated successfully, and then you made it out of your hospitalization, you got discharged home? That's only 6%. So our survival rate from initial cardiac arrest out of the hospital alive, 6% in San Francisco. That sounds dismal, but it's no worse than any other county, any other community. It was approximately 10%, 5 to 10%. Now, if you look at those causes of sudden death, 98% were cardiac. Okay, so 98% of sudden cardiac arrest survivors were indeed due to cardiac cause. And that's where this conflation happens. We only see that 6%. 98% of those are cardiac. Now we equate the two. Okay, it's got to be cardiac, all the cases we didn't see. Let's keep trying to save those cardiac. Let's iterate better ACLS, better ICDs. Well, what's that going to do? That's only going to save the arrhythmic cases. You're going to completely miss all the other non-cardiac causes, right? So along the chain of survival, the further along the chain of survival you get, the more likely you are to be arrhythmic or cardiac. No surprise, because all of our protocols only save cardiac causes. And so if you look carefully, What's missing? So it turns out among the initially resuscitated cases, about 9% were due to neurologic causes. And these are almost always intracranial bleeds. And so intracranial bleeds, it turns out, whether it's intracranial bleeds or severe seizure, 100% mortality if that was your underlying cause. We saved none of those cases. Again, no surprise, because we're not even thinking that it could be neurologic. We rush them to the cath lab, we defibrillate them, right? What about all the other causes like pulmonary embolisms, like hemorrhage, overdose? Those are all low-hanging fruit based upon our data that we could use feedback for more precise resuscitation. So in fact, you could imagine in fact, this is a new collaboration I have with EMS and emergency medicine collaborators, where we use our data to potentially predict high likelihood neurologic cases, for example. And if you have a high likelihood of neurologic cause, in our study, it turned out if you were a woman, if you were on anticoagulation, if you had prior stroke, those 3 questions identified a much higher likelihood of a neurologic cause. And what if you answered yes to those 3 questions? Maybe you get triaged to a stroke center, or at least a center that has both capabilities. So STEMI center plus a stroke center would give you a chance to save that 9%, which has 100% mortality as of right now. Okay, so that iceberg, this iceberg cartoon I show you, if you flip it around, sudden cardiac arrest survivor and sudden cardiac death, they're not the same thing. Sudden cardiac arrest survivors, 98% of the time are cardiac. Sudden cardiac deaths, only half the time are they actually arrhythmic. So I have started in my papers to call this presumed sudden cardiac death, right? Because I mean, using that definition I just showed you, it's almost a coin flip, whether it's cardiac or not. And so I was lucky enough to be invited to this commission, and I was able to convince the 20 other commissioners who come from all of these different areas in sudden cardiac death, cardiac arrest, and in the hospital, survivors. We now have agreed these are presumed sudden cardiac deaths, okay? And the cases that die out of the hospital and have a non-cardiac cause or did not meet sudden criteria, we call them non-sudden deaths now. Presumed sudden cardiac deaths, and if you have had an autopsy, toxicology, and histology, and I made sure to advocate for all the 3 of those things, because often only autopsy gets done, maybe histology, almost never toxicology, but you're gonna miss all those cases that I showed you, right? So presumed sudden cardiac death, you get the full postmortem, then you can be declared a sudden cardiac death, okay? If you identify a non-cardiac cause, you're in sudden non-cardiac death. You're still sudden because you met the WHO criteria, but you're not cardiac, sudden non-cardiac death. And then this population, as I showed you, 5 to 10%, the lucky 5 to 10% that make it out of the hospital, those are sudden cardiac arrest survivors. So, you know, I gnash my teeth when I hear people say sudden cardiac death, you survived sudden cardiac death. No, you did not survive sudden cardiac death, you survived sudden cardiac arrest in my clinic. So how I just told you, all the people who had amassed cohorts of sudden cardiac arrest and sudden cardiac death using the presumed definition, well, are those, should they throw all those cases out, right? Well, James Salazar, who has been working with me since medical school and has done amazing work, he led this actually as a medical student. And so what can we do? What we can do is use our data to help other investigators identify high likelihood cardiac and arrhythmic cases among their presumed cardiac cases. And so using our study, we're able to suggest refinements to WHO criteria. And so for example, based upon data, if you restrict unwitnessed sudden cardiac death, or witnessed sudden cardiac deaths to ventricular fibrillation rhythm, then much higher likelihood to be arrhythmic cause. Not 100%, as I showed you, but much better. Unwitnessed cases, if you restrict that unwitnessed window from 24 hours down to about 1 hour, that really does help specify arrhythmic cause. And so if you take all of the etiologies over on the left, in green are all the non-cardiac causes, in red are all the arrhythmic causes, and then on the right are all the predictors for, in green, predictors of non-arrhythmic cause, in red, predictors of arrhythmic cause. You can begin to refine other cohorts to approximate truly arrhythmic deaths. And so we actually, or he actually derived a risk calculator down here, an arrhythmic death calculator, free for download for any investigator who's interested. And what you do is you plug in your age of your case, plug in race, plug in time since last seen normal, plug in medications, plug in rhythm, and it outputs a likelihood of arrhythmic death. And so now you can begin to refine your cases instead of just a coin flip. I want to refine my cases to 80% likelihood of arrhythmic death, for example, right? And so unless you do that, you use the other definition. What are you trying to predict when you read these papers that say sudden cardiac death predictor algorithms? So how might you use that in a practical sense? As you guys may know, and as I alluded to earlier, Jeff Olgan and Byron Lee led the VEST trial, published about 5 years ago. And as you may remember, the controversy was this borderline effect of the VEST on arrhythmic death. P-value was 0.18 for benefit in people receiving the VEST. And it turns out, if you look carefully, of 1,500 people, they had 25 events in the device group. 1,500 people, 25 events in the device group that they called arrhythmic death. And then the control group, they had 19 deaths they called arrhythmic deaths, okay, with a p-value of 0.18. Okay, based upon 25 events against 19 events. Okay, and I just told you, he in fact tells me that he had to rely on obituaries sometimes, let alone death certificates, to adjudicate their outcomes. So imagine using our calculator and flipping this, maybe this becomes 28 or 29, maybe this becomes 16. And so you have a better resolution, or perhaps the other way around. Perhaps they're actually more equal. Using our calculator, you can go back in clinical trials or any other cohort studies and perhaps refine these estimates that they've published. So going back to this slide, WHO defines sudden cardiac deaths should be considered presumed sudden cardiac deaths. This is about a twofold overestimate based upon our data, as I showed you. This is about a 50% underestimate. So sudden neurologic cases, strokes, about 50% underestimate based upon our data. And then here, this is not 80%, it's more like 50%. So twofold overestimate. In the contemporary era, our primary prevention, our primordial prevention is getting better. The device substrate is changing. About half, not 80%, are due to coronary disease. That's made up by an increase in these cardiomyopathies. We see hypertrophy, you see dilation without coronary disease. That's now, according to our data, a twofold underestimate. And for the rare diseases, if you actually use toxicology in those autopsy negative cases, often they're positive. So it's not 5% normal heart autopsies, it's approximately 1% normal heart autopsies. And so, in summary, WHO defines sudden cardiac death as presumed sudden cardiac death, or simply sudden death, right? All we can be sure is a death happened. That's it, right? Otherwise, it's a guess. We can use criteria to refine it to suddenness, yes. But whether it's cardiac or not, it's a guess without autopsy. As I said, restricting witnessed cases to VTVF or unwitnessed cases to less than 1 hour symptom duration can improve specificity of WHO for actual sudden arrhythmic death, and interpret sudden cardiac deaths in randomized clinical trials and cohort studies with caution. In fact, I would argue not just sudden cardiac death, but causes of death in general. Any aggregate mortality statistics, if it's based on death certificates, it's going to be a guess. Sudden cardiac arrest survivor is not the same as sudden cardiac death. Sudden neurologic death, that's 5% of sudden deaths, and 20% of resuscitated cases, but as of this point, still 100% fatal. High impact is a high impact target to improve survival, especially in women. Overdose sudden deaths. So here, as I said, we've been doing this in San Francisco County, but we consider the universal use of reversal agents. And there are reversal agents for other drugs, like flumazenil for benzos, for example. CIED problem, CIED, cardiovascular implantable electronic devices. Huge gap in surveilling for these problems. We're spending $20,000, $25,000 implanting these devices. We're not even paying attention to what might be causing them to fail. Heart failure sudden deaths, a huge gap. We can improve goal-directed medical therapy in our victims. Perhaps just that alone would have reduced the burden of sudden death among people with heart failure. And then reduce barriers to ICD implantation or ICD utilization. Of the cases that met criteria, the vast majority didn't ever get a referral to get an ICD. And then novel risk factors, as I pointed out, homelessness, HIV, and other forms of immune dysregulation, interstitial myocardial fibrosis. And I'm going to leave you with the next phase. So I haven't shared with you what we've been working on, which is the next phase. Why did we do all this work over the last decade? To hone in on all our cases that are precisely cardiac. And within those cardiac causes, we can know which ones are hypertrophy, which ones are HCM, which ones are dilated, which have early coronary disease, and then begin to dissect molecular studies or perform molecular studies in those cases. And so here's an example of the problem. NIH sunk millions and millions of dollars into this study, which was trying to look at genetic predictors of sudden cardiac death in the community. And despite nearly 4,000 cases and 26,000 controls, completely negative study, GWAS. They had enough power as GWAS, negative study. The reason is the way they defined sudden cardiac arrest was EMS defined. So I just told you, not only are half of the WHO defined cases not cardiac, but another half of the EMS defined cases are not sudden nor cardiac. Okay, so I'm sure there's a signal in there somewhere, and we are hoping that they might use our risk calculator, our arrhythmic death calculator, to refine their cases, and perhaps they actually do have a signal in those cases. And so what we can do, like I said, with phenotype, is do these molecular studies, and I hope to share that in the future. So with that, none of this work would be possible without an amazing team. I again want to shout out Dr. Moffitt. She did all the work in our study. I get the fun job of reporting these data, my granting agencies, and then a special thanks to all the victims of sudden cardiac death in San Francisco who made the ultimate sacrifice so that we can learn from their tragedies. Thank you.
That was terrific. Thank you, Zian. You said reconsider, a few questions and we'll open up. Reconsider the use of reversal. So it sounds like it was considered and rejected. Looking at your data, it seems almost like a no-brainer that it should be part of the resuscitation cookbook.
Yeah.
Why not?
So you're preaching to the choir here. I think EMS sometimes had considered those as futile as one explanation. The other is some do feel like there is a cardiovascular depressant effect of Narcan. So we've argued that despite that can be saved, that can be resuscitated, but the only way to resuscitate an overdose is a Narcan, for example.
And now that you have this acute awareness of the prevalence of device malfunction, devices that you yourself put in, how does that change your management of your folks with devices?
Okay, great question. First, there's a particular company I don't even use anymore based upon our data. Second,
you're not going to mention it.
It's in our data, and all my fellows know what I don't use, and it's simply because they were very dismissive of our concerns. Number one. Number two, their device problems accounted for 80% of our problems. Wow. And so now, what was the main problem was undersensing, as I said, and so the field has moved to long detection intervals for ventricular fibrillation before you shock, because that's one way to avoid inappropriate shocks. AFib causing RVR, let the device discriminate that from VF. Well, it turns out there's a cost to that. The cost is the longer you have ventricular fibrillation, the smaller the R wave gets. And now the device thinks you return to sinus rhythm. And so almost every single case that I saw were long detection intervals. So I now actually program my devices quite short.
So that's you're in
yes,
control of that
yes,
program.
exactly. And so I'd rather my patients come to my clinic, complain to me about an inappropriate shock, than for me to find out later that they died suddenly because we missed the ventricular fibrillation, for example.
My last question will open up. There's some folks here, and I'm sure online, who are young folks thinking about research careers. What do you think the lesson is from your phone call to Dr. Moffitt? I mean, I'm guessing that was the first time she was ever called by an investigator for a collaboration, and it's obviously been transformative for you. So any general lessons that you take from that as you counsel when young folks come to you for mentorship?
Sure. So I have two big recommendations, or two big lessons I learned. Number one is, or three. Number one is other motivated, smart people are willing to help. You just have to ask. I had to be connected to her, but once I got her on the phone, I mean, it was an amazing partnership. Number two, don't be afraid to dream big. Don't be afraid to ask the big questions. the biggest possible question, because that's how you're going to make the biggest impact in your research. The significance portion of an NIH grant is huge. What's the significance of this problem? Huge, 500,000, right? The third thing is that was just the beginning. And to maintain humility and maintain your lens wide to look at all these underlying causes, because I could have very easily narrowed down to the cardiac causes, but we have maintained our lens quite wide because this is a window into death, into causes of sudden death that are unavailable in any other study. In fact, the other lesson I would say in general is we as clinicians ignore these deaths often, right? Yet that is the highest yield type of case to study to see what we did not prevent. What failed? What did we not do right to prevent that death?
So I'll add another lesson, which you're too modest to say, which is that you be a really good collaborator and a really good partner. And yeah, I think it's obvious as you hear all of the shout outs of your partners that you are that. So I think that's incredibly important. Questions or comments? Yeah.
There's a couple from the audience that I'll summarize. One is, what's the impact of COVID on sudden cardiac death? One is, what about the role of kind of counseling families about autopsy? And how do you counsel clinicians about what is the cause of death when you don't really know?
So the first question was about COVID. So in fact, we just got funding to look at COVID and underlying causes. And what I didn't share with you is that 40% of families that we've reached out to have generously agreed to donate their specimens to our study. So we have a biobank of blood and heart specimens and other tissues that we are able now to look at things like HIV, reservoirs, and COVID, for example. So we are a little bit of a victim of our success in the fact that COVID rates were quite low in San Francisco. So we didn't have that much of an impact. Nevertheless, we have seen very, very interesting signals in our sudden deaths, and I'll leave it at that. So that's the COVID question. The second question was?
Autopsy, counseling, and also cause of death.
So of course, autopsy is a sensitive issue. And in the hospital, particularly, as many of you have encountered, out of the hospital, it turns out many families want to know because these are unexpected cases. They want to know. In fact, they're upset often when you don't have an answer for them. What was the underlying cause? Because they want to know for their own sake, for their own family. And so I've been quite not initially surprised, but now it makes a lot of sense why families have generally agreed to autopsies. The third question was about
counseling people when you're not sure, when actually you may give them a false sense of certainty that you know. It's clear that a lot of times you don't. Exactly.
Now in hospital deaths are a different story because you have the workup, you have lab tests, you have imaging. Even without autopsy, you have a better idea of the cause of death, but still surprises in the hospital.
Other questions or comments? Let's see how we have time. We have a couple minutes. Any idea why the rate's higher in Black women?
So that's a good question. I think it's multifactorial. Certainly genetics is probably a factor. Number two, disparities in access to care, in accessing care, in getting care, in having potentially symptoms recognized. I mean, these are hypotheses and we can look into those. In fact, we will look into those underlying causes.
And the heart failure finding I found interesting. What does it say we should be doing? I mean, does that mean more echoes in people, and particularly because a lot of these undiagnosed heart failure folks did not have reduced ejection fraction? So what does that imply in terms of policy or medical guidelines now that we know that there are a lot of undiscovered sudden deaths that seem to be associated, whether it's caused by or associated with heart failure?
Yeah, so I actually have a medical student working on that problem in general, not just in heart failure population. What is the access to care of all these victims in general? Access to a primary care provider? Did they have their hypertension treated? To answer your question, I think it's both. It's these victims often never even had access to care. Okay, they had intermittent contact with care, and then of the cases that were connected. They often did not go through what would be guideline-directed recommendations for prevention. Mm-hmm. And even if they did, compliance is another issue. Adherence is another issue as well. And so, this is a window into this issue, the community overall. what's happening in the community, what's causing sudden deaths in the community. And it's amazingly different than what we read about in our window into the people we care for, the people who come to our clinics, the people who have adherence to our clinic visits, the people who have insurance, for example.
I think we're at time. That was wonderful, not only to talk, but also just to see the trajectory of a career and how you start with an idea and build it over time and really become the world expert in an important topic. So thanks so much.
Thank you.
Really appreciate it.
Thank you.